Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Thank you very much for joining the second monthly online journal club organized by the Young Surgeon Advisory Committee of the Surgical Oncology Society of Pakistan. We welcome you all. We have today's agenda. We will be discussing the FLOT trial, looking at the perioperative chemotherapy for resectable gastric cancer, and it compares two chemotherapy regimes. We will, our presenter, Dr. Pashmal, is just joining us. And Assalamu alaikum, Pashmal. We can't hear you because you're muted. But that's fine. I welcome our faculty, Dr. Awais Amjad Malik, who is a surgical oncologist at Lahore General Hospital. He has been in this institution for, I think, more than 4 years now. Dr. Awais, am I correct?
Yeah, 5 years now. Yeah.
5 years, mashallah. And I also welcome Dr. Muhammad Kashif Khan, who is a surgical oncologist at the Federal Government Polyclinic Institute in Islamabad. And welcome, sir. Assalamu alaikum. Hope you're well.
I'm doing well, sir. Assalamu alaikum.
So unfortunately, Dr. Hadi Khan had a last-minute commitment that he could not bail out of, and therefore he has apologized for his absence in the tumor board today, in the journal club today as a faculty. We are also waiting for Dr. Asghar Hussain, who has informed that he will join in a short while. So before I hand over to Dr. Pashmal, just going through general rules, kindly keep your microphones muted. And while the format will be that there will be presentation of the article that we are studying today, followed by a critical appraisal. And during that time, you're free to comment or ask questions in the chat, but please keep these comments related to the article in question, rather than management of gastric cancer as a whole. We will move up to that, but after the article has been presented and has been appraised by the presenter. And following that, we will have initially a discussion regarding the article and its permutations on the management. And then we will have discussion on the management of gastric cancer as well. And then if there are any questions, queries at that point in time, you could type them in the comment box or chat box, or you could raise your hand and ask questions directly. So without any further delay, we will ask Dr. Pashmal to present. I will stop sharing my screen.
All right, sir. Multiple 1%. Okay, great. Right. Can you see it, sir? Good.
Yes, that's fine. Thank you. Please go ahead.
Perfect. So good morning, good evening, and good afternoon for some people. I'm Dr. Pashmal Yusuf, one of the trainee registrars in Sheikh Zayed Hospital, Lahore. I am going to present the FLOT trial. So for the beginners, before I go on to discussing the trial as a whole, I would like to give some of the background of gastric cancer. It is the fourth most common cancer in the world. It's especially prevalent in South America and East Asia and Japan and Korea. We have a male disposition, as 60% of cases are occurring in men, and they mostly occur in the 7th decade. So before we go on to discussing the chemotherapy regimens or the perioperative chemotherapy for gastric or gastroesophageal junction tumors, I would like to discuss how we go in treating the gastric cancers. So we have the operable stages, or the stages that are less than T2 or they're just T1. We can go on with upfront surgery and offer adjuvant chemotherapy. We have several trials for that. But we can also go for perioperative chemotherapy for tumors that are larger than T1 or T2. For the metastatic tumors or inoperable tumors, palliative treatment is the only way that we have. So the current standard of care is all cancer cases must be discussed at the multidisciplinary level with a medical oncologist and gastroenterologist, the surgeons, the radiologists, discussing as a whole the patient and their clinical and pathological stages. So gastrectomy or esophagectomy remain the mainstay of the treatment. However, there are multiple trials going on and have been done in the past that discuss if we can use neoadjuvant therapy, perioperative chemotherapy, or adjuvant therapy for these cases. Neoadjuvant, just the neoadjuvant chemotherapy, we don't have a lot of data on that. For adjuvant cases, we have the classic trial and the McDonald trial. For perioperative, there was MAGIC trial that gave beautiful results as far as the results were concerned with median survival rates. And then the French trial, which supported that data, and now we have the FLOT trial. So as far as the MAGIC trial goes, there's surgery alone, which is compared to perioperative chemotherapy with ECF. However, we had some problems with that, as the survival rates are really good. As you can see, the 5-year overall survival rate is 36.3% in the ECF group. However, we did have some problems with 5-fluorouracil being given in a continuous infusion over 21 days, and that was bothersome for patients. However, this did lay the ground for perioperative chemotherapy. Then we have the French trial, which compared surgery alone with 5-fluorouracil and cisplatin, and that also supported the results. And this gave us a 5-year survival of 38%. Now, discussing the FLOT trial, I would like to begin with the title, which is the perioperative chemotherapy with 5-fluorouracil plus leucovorin, oxaliplatin, and docetaxel versus 5-fluorouracil or capecitabine plus cisplatin and epirubicin for locally advanced resectable gastric or gastroesophageal junction adenocarcinoma, the FLOT4, a randomized phase 2 and 3 trial. Now, this was based in Germany, and the prime investigator was Dr. Sala. A brief summary of this, all the patients had gastric cancers or GJ junction cancers. They were histologically confirmed adenocarcinomas of a stage T1 or higher, and they were node positive. They were given the FLOT, the F for 5-fluorouracil, leucovorin, oxaliplatin, or docetaxel in one arm, and the epirubicin, cisplatin, 5-fluorouracil in the other. And the 5-fluorouracil was changed with capecitabine, depending upon the investigator's wish, or if the patient's clinical status did not allow them to continue 5-fluorouracil. So phase 2 trial was done before the phase 3 trial and was published alongside this article. It was published a few years before, and that discussed the rate of pathological compute tumor regression. The results were very good, and this trial went on to phase 3, where overall survival was the results for overall survival were shown. The study type was interventional. 716 participants were enrolled. They were enrolled using the interactive web response-based system on per-muted blocks. 4 strategies were used for 1:1 randomization: the ECOG score, the location of primary tumor, age of the patient, and suspected lymph node involvement. For masking, there was no masking done, and the sample size calculation was done using the MAGIC trial's results, which was a 25% median survival rate, and 658 patients were allocated to be allocated this trial. However, a dropout rate of 15% was increased to a 24%, and they decided to use 714 patients, which was at the end a 716 participant trial. This trial started in the summers of 2010 and was completed by, the last follow-up was in 2017 and was published around 2019. Now, for the inclusion criteria, we had locally advanced disease or nodal positive, where both adenocarcinoma of the esophageal-gastric junction or the stomach without any distant metastasis, and no infiltration of the adjacent structures or organs, no previous surgical resection, no previous cytotoxic chemotherapy, more than 18 years of age, both sexes were involved, ECOG score of less than 2, surgical resectability was seen with the MRI, pre-operative MRIs and endoscopies and endoscopic ultrasounds. The leukocyte count of more than 3, platelet of more than 100, serum creatinine or creatinine clearance of more than 50, and informed consented patients were. All right, so they were given the chance to be in the study. Exclusion criteria showed any patients with distant metastasis were not included in the study. Patients with hypersensitivity to the drugs that were in the treatment regimen of the study, or any contraindications to those drugs, any heart disease according to the New York Heart Association, malignant secondary disease or non-surgical accompanied disease, or acute infections, peripheral polyneuropathies, or liver dysfunctions. These patients were excluded, as well as lactating or pregnant females. So we had 2 arms in this trial. One of them was FLOT and the other was ECF or ECX. FLOT, this was a 4-drug regimen. This was for 4 weeks pre-operatively, and 4 cycles pre-operatively and post-operatively were given. And the cycles were bi-weekly. For the ECF and ECX limb, we had 3 cycles post-operative and 3 cycles pre-operative. And these were, the 5-fluorouracil was interchangeable with capecitabine, which was, the capecitabine was an oral drug, and 5-fluorouracil was a continuous infusion for day 1 to day 21, while capecitabine was taken orally for day 1 till day 21. Now, as far as the outcomes go, the primary outcome was median overall survival. Initially it was disease-free survival, but it was changed to median overall survival. However, that did not have any impact on the results of this trial. The secondary outcomes were histopathological regression rate, the disease-free survival time, correlation of complete response and disease-free survival, perioperative morbidity or mortality, R0 resection, and adverse effects. These were all included in the secondary outcomes. I hope everyone can see this, or at least you have the articles on your laptops or mobiles in PDF form. I would like to go on to discuss the first consort table that is generally used for the RCTs. So we had 716 patients enrolled in the study, and 360 were assigned to the ECF, ECX limb, and 356 to the FLOT limb. Some patients dropped out, some had a metastatic disease that was relieved at a later stage, or there was renal dysfunction. Some patients were given, 2 of them were given FLOT by mistake, 1 patient was given ECF by mistake. So by the end, we had a good 354 and 354. The 1:1 ratio was equalized, and we had these patients who were given pre-operative chemotherapy, the neoadjuvant one. Then we went on to performing surgery on those patients after 4 weeks of their last dose of chemotherapy. And out of those patients, 341 underwent surgery in the ECF, ECX limb, and 345 in the FLOT limb. Now, these patients, they received, some of them died in the course, some of them had dropped out because they could not bear the adverse effects. So we had 187 patients who received post-operative chemotherapy of more than 1 cycle, and 213 patients who received post-operative chemotherapy in the FLOT limb. I would like to discuss this table first. This table shows the baseline characteristic of all the patients. And I would like to begin with age. So you see, age, predominantly they had patients were less than 60 years of age. They were males in both the limbs. ECOG score, it was 0 in majority patients had an ECOG score of 0. Now here I would like to discuss that this is a performance score, the ECOG score, and majority patients are belonging to score 0, which means they were absolutely fit when they went in and they participated in the trial. So this could mean that our results were biased, because fit patients, they can generally tolerate the chemotherapy better than people who are unfit. So we had more people from ECOG, say 2 or maybe higher, or even 1. It is possible that the results could have been skewed to one side of the graph. Anyways, we have location as well. The stomach tumors, the gastric tumors were 44%. However, we have more patients from gastroesophageal junction tumors. These tumors are generally friendly. They have good prognosis. They also respond better to chemoradiotherapy. So this could be one of the reasons that the results of this trial were really good, because the tumors are relatively friendly, the gastroesophageal junction tumors. However, I would like to point out that all these tumor types were adenocarcinomas. Now, the clinical stage, majority tumors were T3. They were node positive, most of them, 81% and 78%. Barrett's, it was not detected preoperatively. And another thing that I would like to point out is the histological classification, the Lawrence type. The diffuse type, which is the more aggressive type of cancer, of gastric cancer, these patients were very less. They're just 27% on either limb. However, the intestinal type, which responds better to chemotherapy, that's 45% and 45% in both limbs. So that could have influenced the success of this FLOT trial. Signet cells, there were no signet cells detected in 65. These ratios are comparable, so we're going to skip them. Now we are going to discuss the pathological results. And here I would like you to notice that the tumor surgery was received by 87 and 94% patients. The majority patients received tumor surgery in both limbs. Gastrectomies and esophagectomy were more common. Also in both limbs, the results are comparable, 56 to 58%. There's another thing that I would like you to notice, that D2 resection was done in majority of patients, 53. But so let's just discuss D2 resection first. The lymphadenectomy. There's a Japanese classification, and they give you the anatomical location, and they divide lymph nodes in subgroups. So D2 is grade station 7 and plus, and D1 is station 1 to 6. So there are very less people who got D1 resection. D2 is an aggressive surgery. You remove most of the lymph nodes. So this could be a reason why the FLOT trial was successful. It was, chemotherapy had a little role to play, and because most of the lymph nodes were out. So there's that. The pathological stage, tumor stage is comparable, 49% to 46% T3. And so there is that. All right, so the Kaplan-Meier graph, it's better if we only focus on the overall survivals. For the 2-year survival, or for people, I can just, wait, we can just look at the results here. Okay, so the pre-operative chemotherapy cycles, 91% in the ECF group and 90% in the FLOT group, they received all cycles. Majority of the patients received all preoperative cycles of chemotherapy. 67% of patients in the ECF and ECX group, they chose to get the capecitabine. 95% and 97% of patients respectively in the ECF and FLOT group proceeded to surgery. And post-operatively, 60% of the FLOT patients, they received chemotherapy. The dose delays were comparable in both groups, 2% in the ECF group and 3% in FLOT group. The completed post-operative chemotherapy ratios were there were 46% in the FLOT group and 37% in the ECF-ECX group. The median overall survival was 35 months for ECF and ECX group, while it was 50% for FLOT group. The overall survival at 2 years were also higher for the FLOT group. However, I would like to bring to your attention that 5-year survival was just an estimation. This was not actually done. This was an estimation based on the MAGIC trials results and these results. However, 2 years results were pretty good. Now we have another secondary outcome. We have discussed the primary outcome of this disease, which is the 5 months survival rate for the FLOT group. I would like to discuss the adverse effects right now. So for the ECF-ECX group, as you can see, vomiting and nausea is predominant. For the FLOT group, there's peripheral neuropathy, which is grade 2, grade 3, 7%. In the grade 3, grade 4, it's 7%. And then there's neutropenia, which is 51%. For the toxic deaths and the hospital admissions were almost in, they were less than 1% in both the groups. And other than that, the infection rates were higher for the FLOT trial as well. And that's about it. The others, they are more or less comparable. As you can see, there's stomatitis is 30%, 20. The rest of them are comparable. We'd like to look at the ones who are showing some difference in their results. So this is the forest plot for both the groups. This shows that the forest plot is generally showing that the hazard ratio within 95% of the confidence interval is favoring the FLOT trial. In all the baseline characteristics, everything is falling towards it's favoring the FLOT trial, and so this is about that. And at the end, something that I did not touch up in the beginning is how to critically appraise some of the things I have touched on, but as far as the plot of this randomized controlled trial goes, there are a lot of yes, as you can see. So this is I'd say is a good trial. It did include all the population that was explicitly described. The intervention and control was explicitly described. The setting was described. The outcomes are described. They are validated and are measured using the validated measures. The study is adequately randomized. The method is described. The blinding level is reported that this was not a blind trial. The level of blinding could not have affected the interpretation. Both groups are treated the same way, and they are similar at the baseline, and they were accounted for at the end of the analysis. And they were all of them had an intention to treat. Both the groups, they were intended to be treated. So there's that. All clinically relevant outcomes are reported. All the direct statistical analysis between groups, they have been done. The report, it gives you an appropriate test statistics and clinical relevance and everything. So this is good. However, there are some unanswered questions in this trial. With some of them, I have already discussed the ECOG score. Most of the patients had, 71% patients had a score of 0. More patients were from the gastroesophageal junction tumors. Histological type, more patients had diffuse type. Most patients had intestinal type. Side effects, we have discussed them. Neutropenia can be a very bothersome side effect for an oncologist because you do not want a lot of infections in your patients. And nausea and vomiting, well, that also, but more neutropenia and infections. Surgery, most of the patients had D2, an aggressive surgical procedure. 90% completed their preoperative chemotherapy, and 46% only completed all cycles. Significant improvement in overall survival, as we just mentioned before, but 50 months of median. And the 5-year survival rates, they remain less than 50%. So we need more trials to support this data. The future, we have gastric cancers, we have seen that they are HER2 positive. So we need trials, more trials, and maybe we can add into the FLOT trial and get better results. TOGA trial has shown that the overall response, however, the response is not that comparable, but it is 47%, is about a 10% more than when given alone. So there's that, and there are 2 famous phase 2 trials going on for EGFR antagonists, the FLT and the DOLSTEX, and we need more phase 3 trials to discuss, to see if any other adjuvant chemotherapy is needed for these results. Also, we have some of the so we have trials going on for chemotherapy and radiotherapy. There are trials going on for anti-HER2 new antibodies or anti-angiogenic agents or immune checkpoint inhibitors. So these can be added to the chemotherapy regimen and get better results. And these are all ongoing trials. So the take-home message would be that the treatment of gastric cancer, it is tailor-made for each patient. You have to decide on the clinical stage of the patient and their performance score. What sort of do they directly go for surgery, or or does it look like that they can benefit from chemotherapy, perioperative or adjuvant? FLOT trials have shown the FLOT trial has shown beautiful results. So this at least should be considered in all patients. The MDT meetings are very important for any decision making regarding the treatment. So that's about it. I'm going to hand over to Dr. Raza to take it from here.
Thank you very much, Pashmal. That was very nice and very well presented. I'm happy that the bar that's been raised for in terms of, sorry, I have to mute a few people. So the bar has been set quite high, I think, the last presentation as well as this presentation. Thank you very much for your effort in explaining this article in detail. I have one question to ask.
Yes.
Would you, so in the light of the FLOT trial, first of all, would you change your practice for a reasonably healthy and a patient with good functional status who presents with a resectable gastric cancer, which is not metastasized? So I will pose this question to you and then followed by to our faculty members.
I think I would definitely, looking at the survival rates, I would definitely want a fit patient to get FLOT as a treatment regimen. However, if they are not very well, I would regress to the MAGIC trial, the ECF, or I would even go for maybe just the oxyplotine and just the capecitabine. Maybe a duplet would do for sick patients, a triplet for somebody who's better, and FLOT for somebody who's absolutely fine. So yes, I would prefer FLOT in a healthy patient. Yes, sure, definitely. So.
Dr. Kashif. Would you offer
certainly.
perioperative chemotherapy, and would you change your practice based on FLOT? Or did you change your practice based on FLOT?
Yes, certainly we have changed our practice based on FLOT, and it's a very good trial. Actually, I would label it as Magic Trial plus plus because it's based on the Magic Trial, and they have added a more effective chemotherapy agent in the form of docetaxel, which the data they got from the patients of who had metastatic disease, and they replaced cisplatin, which is a slightly more toxic, with a relatively less toxic and equally effective oxaliplatin. So it's certainly a practice-changing trial, and it's time to move from Magic to FLOT4, and but it continues to. There is the same question because it also takes along with it the controversies that were related to the Magic trial. That Magic trial, it is basically a next form of Magic trial. So the controversies still continue to be there, and we would be discussing them. But certainly for gastric cancer, it is practice changing. And to add to that, my point is, do the patients with a bad ECOG status, would they be better with Magic? I doubt a bit. I doubt that.
I would agree, and I will just raise this question. We have Dr. Asghar and also Dr. Rafia, who I'll introduce both of them. Dr. Asghar is a clinical oncologist at Kiran Hospital, Karachi, and Dr. Rafia has also joined us is in the audience, who's a clinical oncologist in Noor Islamabad. So we will pose this question to them as well. Before that, I'll ask Dr. Awais, have you changed your practice based on the FLOT trial?
Correct. So I agree with Dr. Kashif that this is a practice-changing trial. The trial is executed wonderfully. The results are very convincing, but we have not been able to fully implement this in our practice. So I don't know what's the reason for that, but our patients have a lot of toxicity as far as FLOT4 is concerned. So talking with my oncologist, we were just discussing yesterday, only like 20% of patients with gastric cancer, or maybe even less, are suitable candidate for FLOT4. And there are a lot of reasons for that. Not just toxicity, but cost is also a major issue, because these patients have to get admitted for the chemotherapy, and the cost gets more, the number of cycles are more. So a lot of patients are not able to get this chemotherapy. So I agree, as far as the evidence goes, I fully support that we should be shifting to FLOT4, but practically speaking, we are not there yet. We have not been able to take all our patients and start them on FLOT4. And I think Dr. Asghar can comment better on that, what is the main reason for that, but we are still not at a place where all the patients are being offered FLOT4.
Dr. Asghar, thank you very much for joining us. Question to you. How did you change your practice based on FLOT trial? And obviously, the trial has great results, but sometimes the trials are in a very controlled environment, in a controlled setting, and the real world data and the real world experience is a little different. We would want to know your experience. Did you change practice, and how was the experience?
I think thank you, Radha. I think we have changed for last 2 years back. When it was in 2019, this trial had come, and we have started using this, and we were using this Magic ECF or ECX at that time. The problem is that in both regime, with the FLOT or with the ECX or ECF, the toxicity is almost same. That was also in the trial also. Toxicity is almost same, neutropenia is almost same, but the issue with this FLOT is that here is a docetaxel. Docetaxel, you can say that it's having some reaction, inferior reaction, due to which patient gets some problem with the FLOT. But you can believe on this that with the FLOT, we have more magic result as compared to this Magic trial. And we even at the first dose of this FLOT, the patient do respond very well, and we were quite happy. And I can recall my 2 or 3 patients who even couldn't come back for the surgery after the 4th cycle of the FLOT. So FLOT is, I think, it's incorporated in the guideline also. This is standard of care now, and we're using that. Some oncologists may be feeling they're not comfortable with that only because this cost is, as you're saying, and definitely cost is an issue. But the toxicity with specifically the drug reaction with the docetaxel, because we have to preload this patient with the high dose steroid. If you're not going to load them with the high dose steroid, then definitely we are going to have reaction with the docetaxel. So we have modified it in some way else. I used paclitaxel as compared to docetaxel in one trial, in one patient, and in one patient I have to omit this docetaxel. I started with this 5-FU leucovorin and oxaliplatin, and patient do respond very well. So up till now in my practice, whenever there is a problem with this docetaxel, I just stop this docetaxel and continue the rest of the FLOT, and patient do respond to it. So I think this is the standard of care now, and almost all big centers are using this FLOT, and we're quite happy and quite comfortable with this regime.
Thank you, sir. I would pose the same question to Dr. Rafia. If you can just provide some comments on what has your experience been in using FLOT? Have you changed to FLOT, and how do your patients fare? We can't hear you, Dr. Rafia. I think while Dr. Rafia's audio is sorted out, this question actually arose in my mind, and I would save it. So the MAGIC regime, when it was tested in the MAGIC trial in 2006, it showed median survival as... Oh, sorry. Please.
My experience is FLOT is not of cost, but of now am I clear?
I think there are some audio issues or network problems. Anyway, I'll ask my question. So the MAGIC trial in 2006 used the same regime, ECF, and that showed a median survival of 25 months. In FLOT, the median survival is 35 months with the MAGIC regime, the same regime. And even if we move forward to the critics trial, which kind of was held around the same time as FLOT, and it looked at periop chemo alone versus preoperative chemo, surgery, and post-operative chemoradiation. It was a very well-designed trial, published in 2018. So the critics show median survival 46 months. Why do you think there was difference in the same regime? It's either ECF, either capecitabine instead of 5-FU, or oxaliplatin instead of cisplatin, but more or less ECF, ECX, EOX, the same regimes were used in 3 trials, but we see different results. What could be the reason for that?
Can I answer that?
Yeah. Sure, sir.
So my impression is, I think it's the surgeons who are to be blamed, or who are responsible for this. So the D2 lymph node dissection in the MAGIC trial was very less. I think I don't remember the exact number,
but 27% in the 27%. Sorry.
Exactly. And
27%. Yeah.
Yeah. So 27% in MAGIC trial and 50% in this trial. So the D2 lymphadenectomy, the lymph node dissection was adequately done in the other trials, and that is, I think, the main reason for improved outcomes in between different trials. So it's the same regime, different trials have different survival outcomes because of different types of surgeries that are performed. So we can never understress the importance of surgery. So we still have to.
Dr. Kashif, would you like to?
Sir, you were talking about. Sir.
Sorry, I did not go.
So, sir, regarding the critics trial, actually, MAGIC trial was conducted a bit earlier, so there was less extensive nodal dissection. But as far as the critics trial is concerned, it is basically the poor tolerance to adjuvant regimens that did not prove anything in the critics trial, and particularly the adjuvant radiation component of it. So adjuvant radiation, I suppose I'm not an expert on that, requires a lot of expertise and is difficult to deliver, and toxicity can increase, particularly in case of adjuvant radiation therapy.
Yeah, fair enough. But the question was not the effect of the radiation. It was just that the three arms of these trials that looked at the perioperative chemotherapy only. If you look at the survival for these three arms, so the chemotherapy arm for MAGIC trial, chemotherapy arm for FLOT using the MAGIC regime, and the critics trial chemotherapy arm that used the MAGIC regime, their survivals are different. I think my, sorry, what would you say,
I would
Dr.?
add one more point to that. One was the nodal dissection and other is the staging.
Sorry, sir, you're muted, Dr. Kashif. So you were saying something about the staging.
Yes, I was saying that we have improved in surgery as well as the staging. We have got better CT machines and we are able to better classify and detect the disease. So the disease is not being understaged.
Fair enough. But I would like to kind of take Dr. Abbas's point forward before I pose the same question to Dr. Asghar. I have the same bias as you because to clarify it even further, the critics trial had a very well-defined surgical policy. They've even had presentations on how they standardized the surgical operations in the trial because it was a multi-center trials in different centers in Europe. And their standard dissection was D1 plus as defined, and you would know. More than 80% of patients in critics trial had D1 plus dissection. And because they were done at the same time, more or less the same time as FLOT. So FLOT included patients from 2010 to 2015. Critics included patients from 2007 to 2015. So more or less the same time, same staging, same perioperative or post-chemotherapy care. I think, especially because we can see a difference in the extent of the operation or standardization of the operation technique, I would agree with Dr. Abbas. So sorry for pinching in my 2 cents of bias into this question. Dr. Asghar, why do you think there is a difference in the 3 trials with the same chemotherapy regime?
I think definitely the change of all these surgical techniques also, even in Pakistan, I mean, up till now, ma'am, almost 80-90% surgeon are not doing D2 resection. And this in the same picture, maybe over there also, they might have been starting D2 resection later on. And incomplete staging, incomplete surgical staging, incomplete this your initial performance status of the patient proper maybe there, because the things are being changing day by day also. Initially, in the MAGIC, there was saying that we have to give 5 FU in 21 days continuous infusion. But then they switched them to auxiliary this capecitabine because they were saying that it's very difficult for the patient to continue with the 21 days regime of the 5 FU. They switched to the 5 FU, capecitabine also, and then also they switched them to further 5 FU reduced dose with the completing in the 5 days also. So actually ECF has also modified so much time with ECX and then EOX and all these things. So I think the things were changing. Therefore, this could be the reason there was some difference in the oral survival and all these things. But I don't know that this is going to have a big impact on our further treatment scenario, because now it's a big difference in FLOT and the MAGIC, and it has been shown in the median overall survival in this FLOT4 trial. So I think now the things are much better now. Now expertise are much better now. CT scan and in the radiation planning are much better now. In the MAGIC and in this plot, there is no radiation, but initially we used to give them also this radiation in the McDonald regime. So all these things that change with the time. So I think so we're getting better results now.
Thank you. I think that's great. One small question that FLOT actually changed or touched on something that we consider quite dismal in terms of prognosis, cancers with signet cells. And it actually showed an improvement in outcomes for patients who had signet cells. Now, normally a young patient who presents with a signet ring cell cancer, we tend to be very less optimistic regarding their prognosis. Um, have you seen in real life experience of FLOT patients with signet ring cell cancers responding well and then going on to have an operation and then surviving through it?
I can't recall even a single patient with a signet ring surviving up till now, because signet ring, even the good treatment with good surgeries, also with completion of the chemo, also the survival is quite poor. And most of the time, signet ring, whenever it's coming, it's quite advanced disease. There's most of the time nodal deposits also. They're quite young patients. So survival is signet ring, not only in the case of the gastric, in the case of the rectum is also very poor. So we have a very bitter experience with the signet ring. Yes, we have few patients who survive, but not signet ring. So adenocarcinoma coming with a signet ring is not a good sign for the patient.
Dr. Awais, Dr. Kashif, any of your experience with signet ring cancer?
Sir, it's not been long enough for us being on FLOT to comment on this thing.
Fair enough.
Yeah, no experience. I can't comment on this.
Dr. Rafia,
I have treated few patients with signet ring in the Kiran also, in over here in MMI also. Signet ring patients same way do respond very well to this your FLOT regime also. And we have gone for the surgeries also with the good surgery. Most of the time these surgeries coming with the nodal positive disease. So whenever there's a nodal positivity disease, in the case of the gastric cancer, there's a 50% down the survival. So whatsoever is a good regime where you have used either FLOT or MAGIC and all these things, these patients are coming back very soon. And what is the site of recurrence is most of the time site of recurrence is the nodal deposits or mantle deposit. So these are the two major sites, the patient coming back with the nodal deposit and then coming with the SIT, and that's a good down the survival. So patient signet ring also do respond very well. But overall survival, if you ask me how many patients survive, I can't recall even a single patient with the signet ring surviving very well.
Dr. Rafia had some connection issue, but she has posted her comments that their experience rotates more around the performance status. If it is ECOG 1, then all goes fine. But if performance is more than 2, then difficult to give even ECX or ECF. Thank you for these comments. I would like to invite Professor Khalid Durrani. He's joined us, and just to put forward his observation regarding the trial or the discussion. Professor Khalid Durrani, sir.
Can you hear me?
Ji, sir, bilkul. Thank you very much for joining us. It's an honor for us that you're here.
Thank you so much, Dr. Raza. It's a real pleasure seeing you and a lot of our colleagues are in the audience. So I have already sent you my observations. I think the positive aspect of the FLOT trial is that it has been carried out in a country where they have standardized the treatment of cancer, and including the cancer of the stomach. And imagine 700 patients were recruited, and they were followed for a median follow-up of 40 months in 30 German centers. And the treatment protocol was also standardized with majority, almost all patients were received D2 resection, which is remarkable considering the fact that even the latest data from the US registry shows that not more than 10 or 20% of the patients with gastric cancer receive D2 resection. The other point is over half of the patients had tumors of the cardia. So perhaps this trial also addresses the adenocarcinoma patients involving the cardia, and even they included patients with Sievert 1, which in fact technically is an esophageal cancer approaching to the gastroesophageal junction. So really we can't say, we all know that esophageal cancer responds very well to the cross regimen. So a head-to-head comparison of esophageal cancer, particularly the squamous cell carcinoma with FLOT, cannot be made. The there were certainly some confounding factors, like most patients with FLOT arm received, more patients received surgery compared to ECF patients. And 40% of the patients could not complete post-operative chemotherapy, especially in the FLOT arm. And this is also something to be taken into account. The other point is, which has already been taken up by some of our colleagues, is the grade 3 and 4 toxicities, particularly the diarrhea, neutropenia, and infections. And if you look at the data, it's almost more than twice that in the experimental arm. Then as far as our own patients are concerned, we have to consider the cost of the treatment and quality of life assessment scores also, which is also missing in this study. So finally, I may like to say that considering the nature and frailty of our patients and their economic constraints, which our friend Abid Jamal wishes to call it financial toxicity, it may be argued that FLOT should be considered in affluent young patients with good performance status, particularly ECOG 0 to 1, whereas others may be offered ECF or ECO. This is something. And last, I think one of our colleagues also made a comment about that, is the importance of loco-regional treatment by surgery. So I think it is apparent that the D2 surgery is the standard of care as far as loco-regional treatment is concerned. And I think we need to specialize as far as the GI cancers are concerned. There is a need to develop a GI cancer surgical units which especially focuses on GI cancers. So that is another factor which we have to look into, because it's apparent from the cancers of various other cancers like pancreatic cancers or GI cancers or rectal cancers, that the volume is a very important factor. So high volume centers are likely to produce much better results compared to an occasional surgeon performing resections maybe 2, 3, 4, or 5 times a year. And as I understand, currently the minimum number of patients with GI cancer that a unit is required to operate, I think it should not be less than 20 in a year. And in the same vein, I would like to say that the minimum number of lymph nodes in any gastric resection should be between 20 to 25 rather than 15, which is there in the old text that we now consider. With this, I thank you very much, Dr. Rada, and it was a nice gathering.
Thank you so much for joining us, sir. Maybe we have time for a few questions generally related to management of gastric cancer. Because the comment came up about appropriate staging of gastric cancer. So what do you consider appropriate staging of gastric cancer? Dr. Kashif?
Sir, as far as the gastric cancer is concerned, with the available resources, what we are doing is a CT scan chest, abdomen, and pelvis. We also do a staging laparoscopy in these patients. As far as the endoscopic ultrasound is concerned, that is the facility that is a bit lacking. And I personally believe that except for a few cases, it doesn't make much of a difference, but it is certainly preferable as it is there in this trial. And to add, there is a question that did this FLOT4 trial use staging laparoscopy before starting the therapy?
I'll have to look at the protocol itself, but they said that the staging laparoscopy was recommended but not mandatory for all patients. So each center used it according to their own MDT decisions. But I'm assuming it would be very inappropriate to do the staging. I mean, if you select somebody for staging laparoscopy, to perform that after giving chemotherapy would be a little bit inappropriate. So I'm assuming if it's taken a decision through a multidisciplinary team, then laparoscopy would be done before starting a treatment, perhaps even before randomization. Dr. Asghar, how do you stage gastric cancer? Do you add anything other than that? Like, for example, PET-CT? Would you routinely perform PET-CT in gastric cancer?
No, not at all. Not at all. PET-CT is not a definite recommendation. Even the staging laparoscopy before the surgery or before the chemotherapy is a category 2 recommendation, category 2B. You know, most of the people don't agree with this one, but they have written a very clear cut that it all depends on where the patient has gone first. If the patient has gone to the surgeon first, then definitely going for the laparoscopic evaluation first. And this is very well written in the text also. I was very funny. It's a funny statement. It all depends where the patient gone first. If the patient gone to the surgeon, then definitely laparoscopy, staging laparoscopy is the standard of care for them. And the patient come to the oncologist, then it may not be the category standard 1 recommendation. So, but in my opinion, it all depends. If it's locally advanced disease, like you're saying, your CT is saying that the regional lymph nodes are also there, and there is a T3 plus lesion looks to it, then I do recommend to go for the staging laparoscopic first, because this is all going to change the whole of this scenario. If there's a peritoneal deposit, cemented deposit, then I'll say take this patient as a stage 4 disease. So even if the parotic nodes involvement, portal node involvement, it looks to be locally advanced, and but the regional node involvement, in our opinion, this patient also is having the quite advanced disease, maybe having the good result with the chemo, you may be doing the very good surgeries also, but this patient coming back to you very soon with the local recurrence. So PET-CT scan upfront can be done if patient can go for this, but due to the availability, due to the cost issue, we were not recommending so frequently the PET-CT scan. So we're asking the patient go for the simple CT scan. But if you ask me, my choice upfront for staging of this scan, and I'll say if the PET scan can be done, that's good enough for the patient, because it will give the good scenario of this nodes also. It will give you the good scenario of this your peritoneal and mental deposits also. Even then, you can omit this your staging laparoscopy also.
Dr. Rafia, sorry, I've just seen that you have raised your hand. Would you like to make a comment?
Yes, I want to, sorry for the previous one because of connection issue. I just want to say that this financial toxicity is no more a problem at Noori since last 1 year because of this SED card issue. Our problem is with performance status. If the performance status is good, the results of FLOT as well as ECX, they both are comparable with in our institute. They're excellent. But if the performance status is bad, it's lost case with both chemos. That's my only comment. Well, FLOT does have the upper end, but our experience is almost the same with the ECX and ECF and FLOT. Thank you.
Thank you, Dr. Rafia. Important point. Dr. Asghar, do you think that patients who are not affording, can they get FLOT in your institution in Kiran?
The question of financial toxicity does matter, whether this patient is having some chase card solace or also or paying from the own pocket. If you think that the FLOT is the standard of care now, then nothing to worry about this financial toxicity if anyone is going to pay. But if you think that the FLOT is not standard of care now, then why to spend this much money, even the patient going through this health card or by some way other means. So it's not the issue of this financial issue. You see the results also. When you're going to say good response, you have good resectability, good response rate, good median odds of survival, then patient deserve to go for this type of the treatment. Definitely ECOG 1, ECOG 0 patients having the this stomach cancer may not be having a good performance status. But when you see even the patient refuse for any of the feeding tube at that time, we start this FLOT and patient do respond, and even after the first cycle, patients start taking oral very well. When we were planning for go for the pylori stenting or something like a feeding genostomy, we asked the patient, we're going to have a build-up for 1 or 2 days or 3 days. If your blood reports are okay, we're going to take you with the chemotherapy. And even after the 2 weeks, you just see the response. Patients so much happy after this regime, and they start taking orally well. And then they say that we don't want to go for any type of the stenting or don't want to go for any type of the genostomy. So when you have this much good results, then nothing to worry about this financial toxicity. You have a good response. Even in the case of the breast, you're going to give the Herceptin, you're going to give the pertuzumab, where this financial toxicity is coming from there at that time. So when you see the results, you have a good response, then I think patient deserve to go for this type of treatment, whosoever is going to pay. When there is not a good results, then definitely we're also not going to prescribe all these things. So in the FLOT regime, I'll suggest this patient, our oncology should be now have a good courage on that they should start with this your chemotherapy. And in our current, we have alhamdulillah no issue with the financial issues. When there is a need for this, we're going to give the financial roughly this how much will be the cost of this FLOT? Roughly of 15,000-20,000 rupees only per patient per cycle. So I think this is not a big game for the patient, for the Kiran also.
Okay, Dr. Kashif, you've raised your hand, sir.
Sir, I wanted to come to a previous question, and I want to ask you, we have seen that in this study, more than half of the patients are geojunction tumor or lower esophageal cancers. So in these patients, is this study a practice-changing study?
If you ask my opinion, I would refer to the comments in the discussion that they have made in this in the study itself. That yes, especially Sievert type 1, which are defined as tumors with an epicenter more than 5 centimeter proximal to the G junction. They have said that yes, we have not been able to compare this with the results of cross trial, especially for adenocarcinoma of Sievert 1 type G junction. There are few trials that are ongoing, which are actually comparing for Sievert 1 GOJ adenocarcinoma between cross regime and the FLOT regime. And one of the trials that I remember is SOS-PK that they have mentioned. So there are trials that are ongoing, head-to-head comparison for basically lower esophageal adenocarcinoma, FLOT versus cross regime. So hopefully we will have an evidence-based answer to this question.
May I answer in this case?
Ji, sir.
Actually, this FLOT is for Sievert 2 or 3, not for the Sievert 1. For Sievert 1, in our practice and in the guideline also say go for the cross. But it's only for the adenocarcinoma. It's definitely Dr. Kashif's practice changing. And I think when the Sievert 2 or Sievert 3 and it's adenocarcinoma, we should go for this FLOT.
And basically all these decisions have to be made within the confine of an MDT, where an oncologist, surgeons, they're all sitting together and they may come to a consensus based on the individual types of the tumor and the patient what to do. Dr. On had raised his hand, and then Dr. On, did you want to ask a question or comment? In the meantime, I'll read a comment from Professor Durrani, who said that while we're on gastric cancer, any thoughts on SOX regime, including S1, that has shown promising results in Asian patients? Have you any experience of S1?
No. It's not standard of care. It's not standard of care, and S1 is something different from this other regime, or we don't have any good head-to-head trial in the S1 regime, or it's only the Asian people, Chinese, Japanese are going to use this S1, not the other Western people are not going to use this one. So we don't have good data, and also we're not going to use this S1 over here in Pakistan.
Thank you. Now, what about patients who present with extensive nodal disease, but no systemic metastases? I'm excluding periaortic nodal disease. For example, if patient has nodes in the gastrohepatic ligament reaching up to the celiac axis, what would be your MDT discussion and decisions around that patient? In a young, fit patient, localized disease in terms of the stomach, no metastatic disease, but nodal disease involving the celiac axis. Would you consider it with curative intent or not?
And may I answer?
Sure, sir.
The only thing, only recommendation for the surgery, upfront surgery, for distal esophageal junction, I'm specifically saying about the distal esophageal junction, that it should be less than 2 centimeter lesion. It should be well differentiated and it should be grade 1. And almost 90% of our cases are not in this scenario. So what does it mean when the tumor is not G1, when the tumor is not 2 centimeter less, or when the tumor is not having this performance T1, T2 lesion, early stage lesion, all patient needs definitely upfront chemoradiation in for C1 distal G junction. The same scenario over here in this gastric. Even you say that this patient looks to be quite resectable lesion and very early lesion, T1, T2. It all depends where the patient has gone first. But if we're going to discuss all these things in MDT, this patient needs upfront surgery. We don't have any conflict of interest in this case that the patient has early lesion in the stomach, but it should not be having nodal deposits. If there is some nodal deposit, even the single nodal deposit, as you're going to say in the gastrohepatic ligament or in the celiac node, then this patient is not a candidate for upfront surgery. That patient needs a neoadjuvant chemotherapy and not neoadjuvant chemoradiation. Neoadjuvant chemotherapy is the standard of care, and that should be done after 4 cycles of FLOT. This patient needs then surgery.
Dr. Wes?
I would agree with Dr. Asghar, and I would also like to stress over here that there are a lot of surgeons in your group, and there's a tendency among the surgeons to go for upfront surgery for any gastric cancer. We need to understand that chemo plays a very important role in improving the survival of the patient. So we have been doing gastric cancer surgeries for the last 200 years, and the survival has started improving ever since the chemo came in. So we cannot ignore the fact that chemo is important, and we should remember that sometimes when you do upfront surgery, your patient can have some complications and he can lose the chance of having that chemotherapy. So giving chemotherapy before surgery, especially for gastric cancer, is very important. So if you have any patient, I don't see any, I have never seen a patient with the description with Dr. Asghar say, you will never see a very early T1 lesion without lymph node, at least in Pakistan. So we don't have screening, we don't have early cancer. So we have to do perioperative chemo, and we have to do 3 to 4 cycles of chemotherapy and then restage and then do the surgery. And that's the standard of care for us as well.
Dr. Kashif, a comment from you, and then Dr. On has raised his hand, and we'll go up to Dr. On. Dr. Kashif.
Certainly for gastric cancer, now it's FLOT4 trial, and particularly the case that you mentioned, there is no reason we should offer surgery to this patient. And in almost all of the patients that present to us in our OPDs, it's a perioperative chemotherapy.
Thank you very much. Dr. On, can you kindly ask your question?
Assalamu alaikum, everyone. So what I wanted to ask and I wanted to comment was, we see a lot of distal gastric cancers as well. So, a lot of surgeons, including some oncological surgeons and a lot of surgeons dealing with the gastric cancers, would justify the use of upfront surgery, just because the stents are not available, the lesion seems early, the lymph nodes are small, and if you want to do upfront surgery, you can have a million reasons to do that. So what I wanted to discuss on this forum was that what should be our stance on doing these distal gastric cancers, if of course we do not have the facility for stents, because a lot of times we take these excuses that the stent was not available. The patient could not be, cannot be bridged for the chemotherapy. What is the stance of the group on the management of these distal gastric cancers?
Anyone?
Should I answer?
Please, sir. Please, Dr.
Dr. On, it's very simple answer. It's very simple. We should be very honest in such type of cases. When the services are not available, And if you think that patients having the BMI less than 25, less than 18, I don't think so that patient is a good candidate for even the neoadjuvant chemotherapy. That patient needs build up. If stent is not available, go for the feeding jejunostomy. Without feeding, you can't treat the patient even with this neoadjuvant chemotherapy or anything like that.
But Dr. Askar, I have not seen any patient getting built up with a feeding jejunostomy. Believe me, these feeding jejunostomies and elementary diets are not that available like the way they are available in the West. So when I was in Shaukat Khanam, we used to have very good elementary support and internal supports over there. But if you talk about even most of the private setups, they are not having that sort of support systems for building a patient on a jejunostomy. I agree, a gastrostomy can be used, but feeding jejunostomies are hardly even practical in building up the patients. They do.
But on if you're putting this gastrostomy in the pyloric region of obstruction, then how much it will be helpful for the patient?
I mean, I know gastrostomy is already out, the stomach is obstructed. So I wanted to discuss, because even if in those lesions, for example, they seem to be T3 or they seem to be T2, hardly we see any T2. But even if they seem to be T3 at the distal gastric region, when we do the posterior resection, a lot of time the pancreatic capsule is involved. So those lesions which we think into T3 are in fact T4, and at times, and they have all those small less than 1 centimeter lymph nodes that were apparent on the CT scan, in fact, are already involved. So what I wanted to discuss, and can there be a role that these patients can have a bridging gastrojejunostomy? If you have a proximal distance, can we do a bridging gastrojejunostomy followed by a resection?
I will take this question. Maybe Professor Khalid Durrani has raised his hand for comment, sir. Do you have any comment in this regard, sir?
Yes, I think to my understanding, the two conditions, one being gastric outlet obstruction, which Dr. Aoun has pointed out, and the second is bleeding. These are the two relative contraindications to neoadjuvant chemotherapy, and these patients perhaps would be better off by upfront surgery. Unless you can bypass gastric outlet obstruction by some kind of nasojejunal feeding, and you place a tube in the stomach to aspirate the saliva and the gastric secretion, while this patient is being considered for neoadjuvant chemotherapy. Otherwise, most of these patients are candidates for upfront surgery. Bleeding, GI bleeding, and bleeding from gastric cancer and gastric outlet obstruction. Thank you.
Thank you, sir. Dr. Kashif?
Sir, I totally agree with Professor Khalid, and I would also say that it's my practice. At least what I am doing is we go ahead with the surgery first in patients who have got gastric outlet obstruction, and it's my observation that those patients who present with gastric outlet obstructions, they have relatively better outcomes as compared to the patients who have got a gastric cardia tumor or a high up lesser curved tumor. So these patients who ultimately require a total gastrectomy, their outcomes are quite poor as compared to the patients who have undergo a distal gastrectomy. May it be a surgery first approach, and as far as the staging is concerned, at the time of presentation, these tumors are relatively early. So this is the practice that I am following.
I think there will be an individual difference of opinion, but the highlight should be that these cases should be discussed in a multidisciplinary fashion, and that multidisciplinary team should come up with a discussion rather than seeing this patient in the surgical clinic and then taking this patient to surgery. So I would agree, as long as your multidisciplinary team would agree. Dr. Aoun, would you want to say something?
Yeah, I would just want to give a few comments. These patients who we think are T3 or who we think are resectable, in my practice, out of Shaukat Khanam, whenever I have done a distal gastric cancer upfront, I always see them coming back in 3 to 4 months with metastatic disease. So all those fancy doable cases, which we thought are doable, they already had a lot of lymph node burden. And I personally think that if we have a gastric outlet obstruction, somehow we should, arrange a stent or some ways to, relieve the obstruction. And ideally, if the patient is otherwise a candidate of chemotherapy, should be given a trial of chemotherapy. So gastric outlet obstruction, in my humble opinion, should not be taken as a leverage for performing an upfront surgery. And guidelines support this.
Doctor, sir, sorry.
In our practice, when the scenario is like this, when you are stuck up with this surgery also, and when you're not fit for any further stunting also, we have a experience in treating such type of the patient, and some patients having the poor performance status, but not BMI less than 18. We tried with this very low dose chemo, like without oxaliplatin, without this your docetaxel, just start with this 5-FU recovery, which was a standard regime for the McDonald also. In the McDonald regime, they had given nothing but just only 5-FU recovery. And patient do respond very well. Can you believe that we have seen the patient responding within 1 or 2 cycles, and they start taking oral very well. Because 5-FU is a magic drug for this GI tumor. So if you have a problem like this, discuss with your oncologist, ask them to start with 5-FU recovery alone. They should not be having any toxicity except the diarrhea. And if you're going to give them in a continuous infusion, rather of this bolus, you are not having even this diarrhea also. But you see the patient will definitely respond. And rather of opening this patient for going for this bypass surgery in such type of the weak patient, I'll suggest discuss this case in the MDT, talk to your oncologist, ask them to start with a very simple regime with 5-FU recovery, which was the basic regime for the gastric tumor, and you will see the response. And we have treated patients like this.
That's a very valid point about involvement and discussion. Dr. West, how do you manage gastric outlet obstruction?
So again, On and me, we are both working in the same hospital, so we have the same scenario. So working in a public sector hospital, I agree with what Dr. Asghar is saying, but our issue is that we are working at a place where our patients have to travel from one hospital to another hospital to get their chemo. So unless we can stent them, we cannot just send them for chemotherapy. So we end up doing upfront resections. And yes, some patients do well and some don't do well. So the issue remains that unless you can get your hands on a good stenting facility, you will end up with patients who will need upfront surgery, and we still do that. But I think if possible, if we can have, so again, I would say MDT has a very important role to play here. So if you can have your chemo, if you have your medical oncologists, gastroenterologists, and surgeons on board discussing the same patient, I'm sure you can work something out in the best interest of the patient. And yes, sometimes the patients will end up with upfront surgery, but then again, that is again in the best interest of the patient. So if you don't have stenting facility, if you don't have chemotherapy available, then you have to give them something, and then surgery is done. So you have to do upfront surgery.
Thank you very much. I would just relay my experience. I work in a private sector hospital. And I always get a gastric outlet patient who present with gastric outlet obstruction. I always get them stented. I am very blessed to have a very competent GI team in my hospital, and cost is not an issue. In patients who are non-affording, there are mechanisms which can be utilized to cover the cost of the stent. And they can be done free for those patients. So I'm very blessed that I always I have a very competent team of gastroenterologists who are always able to put in a stent, and cost does not come an issue. The issue comes after that, because patients who have had this obstruction, gastroparesis is an issue that has to be managed, and it can be managed with medications. And then they go on to receive chemotherapy, nutritional buildup, and so this is my very humble experience of handful of cases of.
Can I ask Raza one question?
Sir. For
surgeon, being an oncologist, we're facing one problem from surgical point of view. Because you people are doing very good surgeries, you are removing so much from the surrounding gastric tissue. You're saying it's 15+ node is the standard of care for this surgery. But when you see the histopathology report, there is some in the end that the surgeon has removed, let's say 16 node, let's say out of the 5 are positive or 6 are positive. How we can come to know that this is a D1 and D2 resection?
Dr. Kashif, Dr. Avais, would you like to answer?
So technically,
Sorry?
So technically, I think the surgeon would not want the oncologist to know whether it's D1 or D2. So although ideally we should be marking the lymph nodes, okay, which station has been removed, so that we can identify which nodes are positive, which are negative. But generally, that's not the standard practice, and we just send everything as a bulk. So it's technically not possible easily to identify whether it's D1 or D2, and you have to trust the surgeon on that.
But
whatever he has written,
plan
and
is
whether
changed. If there's D2 resection, even the node positive, we don't radiate. This is the standard of care. If the D2 resection, no need for radiation in adjuvant setting. But if it's a D1 resection, we have to radiate also. So what do you think?
So I totally agree with you that ideally the surgeon should be, either you should trust the surgeon or the surgeon should be taking photographs of what he has removed and what was the bed which has been left behind. So if the surgeon is not sure that if the surgeon knows that he has not done a D2, he should properly document it that some of the fatty tissue was left behind, so that if the nodes are positive, that place should be radiated. So that is in the best interest of the patient. But again, Dr. Kashif, your comments, because the surgeons would never compromise on.
Actually, the point is that D2 nodal dissection is actually an anatomical dissection. It is based upon, not upon the number of nodes. Generally, the number of nodal yield would improve with the D2 dissection, but we can get a high number of nodes even with D1 dissection as well. So it's these are the nodal stations that we have to remove. So generally 15 plus is minimum, the cutoff, which and what my experience had been is generally the D2 dissection has got somewhere between 24 to 30 nodes, provided the fact that there was a good pathologist, because I have observed that some of the pathologists count till 15 and 16 and then they stop. So nodal yield depends upon the surgeon as well as on the pathologist.
Fair enough. Dr. On, what would you like to say?
This thing.
Dr. Reza, I would just like to answer to Dr. Askar's point. You know, I think once we are doing a D2 dissection, we have to be honest. The surgeon has to be honest with it. It is not the number of nodes that are being involved. I totally agree to Dr. Kashif's point. It is the stations that are involved. And due to, financial reasons and due to the economical reasons, we do not send every station separately. And even if we send every station separately, that doesn't really make sense. All we have to do is to document honestly that we have done a D2 dissection, sparing station 10, if that is, that is not, meant to be removed. And we have, as surgeons, we have to understand first what is a D2 dissection and what are the merits of it and what are the factors that necessitate having a D2 dissection. So all we have to do as surgeons is to be honest about the fact that we have done a proper D2 dissection and the number of lymph nodes really doesn't matter. In an adequately done D1 specimen, if it is being adequately sampled, you can get in excess of 15 lymph nodes. And in a properly done D2 dissection, one of my dissections, which I grossed with one of my histopathologists once I was out of Shaukat Khanum, revealed actually 46 lymph nodes, believe me. So the fact was that the histopathologist was keen on doing this, the grossing, and he did it himself. So this, the D2 dissection does not really, I think, depend on the number of lymph nodes that you have harvested. It depends on the adequacy that the surgeon has done. And we have to be honest about it. We need to understand what is a D2 thing, and then we have to be honest about it. This is my, 2 cents.
Thank you. Dr. Kashif.
So, Dr. On, you want to say that if the pathologist is a friend of yours, the nodal yield improves as it happened in your case.
What I want to say is, is that we have to be in communication with the pathology people. Once we are outside, a proper oncology institutes, we have to be in good friendship with the histopathology guys, because what happens most of the time is that minimum number of lymph nodes that is required is, for example, 10 in the breast, 12 in the colon or rectum, and 15 or 16 in the upper GI. So what they're going to do is they would find 15 lymph nodes, then they call it a day. So the 15 lymph nodes mil gaye, job well done. 15 mein se 5 involved, only to find out that if they would have done sampling of 30 lymph nodes or 35 lymph nodes, then 10 would already be involved. So this is the fact. I think we have to be in collaboration with the histopathology guys as well.
Thank you very much. Yes, I would
just
also like
adding
to add.
Sorry, Dr. Just adding to what Dr. Azra is saying, I don't think just saying we should be honest is going to solve the issues. I think it should be an institutional policy of that everything should be documented what was done in the operation theater. That is the only way forward. You can't just say कि surgeon ने कह दिया तो D2 होगी, because everybody says they are doing D2. And we all know that generally what is happening is something in between D1 and D2. That is the common practice which is happening everywhere. A D1 plus is what's happening everywhere. So it should be the institutional policy that everything should be documented and maybe photographed for the future reference for the sake of the patient. So at the end, the patient is the most important thing. So for the sake of the patient, everything should be documented. We cannot trust anybody. So to be very honest, we are not honest. So
I think that's a very valid point. First of all, I think D1 plus or D1 alpha is not unacceptable management of gastric cancer, not an acceptable surgical management of gastric cancer. So I would accept that if somebody says it's a D1 plus surgery. The definition of D1, D2, D1 plus would vary if you're looking at the Japanese classification or if you are looking at maybe the Western classification. So most of the studies that actually want to standardize it according to the Japanese classification that this was D2, D1, D1 alpha. And they have described the number of stations for distal gastric cancer. Those numbers of stations that would be called D2 dissection are different. For proximal cancers are different. For total gastrectomy, it's different. The other point is that a lot of times the pathology report, the oncological management is not in the same institution where the surgery takes place. So the oncologists usually rely on the pathology report. And there is a lot of information that goes on our, as surgeons, when we fill the pathology specimen form, that is actually noted down on that pathology report. That is actually our document and message to the MDT where this case will be discussed and to our oncologist as well. So if we just take the extra effort of writing that this patient underwent distal gastrectomy with removal of stations XYZ, then subsequent information can be processed, whether this was D1, D2, the oncologist can then decide regarding adjuvant therapy. This is just my 2 bits of experience.
I totally agree, Dr. Razma. Very valid point. I totally agree to the fact that instead of writing D2, because D2 is different for distal, D2 is just different for proximal, D2 is different for total. We should write the number of stations, and I totally agree to that.
Dr. Kashif, sir.
So, sir, I again want to emphasize what you already have said, that D1 plus is acceptable, and Japanese have got they have again changed the D2 lymph node dissection criteria. And now an article that I was going through, that they have made a database of all of their gastric cancer patients and entering different parameters into the computer. And they have gotten built up an artificial intelligence system in which you enter the parameters of the patient, the tumor location, EUS findings, and all these things. And ultimately, they would tell you, remove these nodal stations, and it would be labeled as a D2 dissection. So now D2 dissection is becoming personalized. So this is my point.
Exactly. So thank you for bringing to that. I think the way Japanese have managed gastric cancer is phenomenal. And Murayama, who is their main surgeon from Tokyo Cancer Institute, built up this program probably 2 decades ago. And well, as long as they have the data of thousands of gastric cancer patients, depending upon the location. And by the way, they got to this information by analyzing each station separately for each cancer. So they had the resources, they applied these resources and looked at, and then that's why they are able to come up with this information. So data is useful whenever we collect it, no doubt about it. I thank everyone. I think we should bring it to a close. We had some international participants. I don't know if we still have them. We have some participants from India. I would like to invite comments from them. Do you manage gastric cancer any differently from the way we have discussed? I can see Dr. Padma Raju. Would you kindly comment how do you manage gastric cancer? I think we have lost contact. Any other comments? If there are no comments, we would like to bring it to a close.
Dr. Raza, I think in the upcoming seminars, which we are planning to have, almost 6 weekly to 8 weekly from the platform of SOS-PK, I think we should include this topic as a seminar as well. And that, we need to define D2 resections, and we need to, educate people on the management of gastric cancers, so that, we can play our 2 cents in the management and education of people. So I think that the gastric cancers need to be redefined for our population. The guidelines are already there, but I think, we can play our little part as well.
Definitely, we will definitely do that. That's a great idea. So this is the schedule for our monthly journal clubs that we will be having roughly on the first Saturday of every month. We have kind of moved this one a bit earlier because of Ramadan. The next session is covering colorectal cancer and will be done after Eid on 7th of May. We welcome you to that. We will be discussing Rapido trial in that session, and Dr. Jibran Mohsen, who's attending now, will be presenting. I would thank everyone and would request Professor Khalid Durrani to give his concluding remarks. Sir, Professor Khalid Durrani.
Thank you, Dr. Raza. It was an exciting discussion from the platform of Society of Surgeons of Pakistan, and Raza, you really deserve a lot of commendation for initiating it and then conducting it very nicely. Just one comment I would like to make is perhaps I was wondering if our oncologist friends look into the possibility of treating H. pylori in patients with gastric cancer, because once the surgery is performed, these patients are transferred back to the oncology department and they are managed and follow up in the oncology department. So we have had very useful discussion, and thank you once again, Dr. Raza and the rest of the colleagues as well as the commentators. Hope to see you next month. Thank you.
Thank you, sir. I thank all our faculty, Dr. Askar, Dr. Kashif, Dr. Awais, thank you very much for being with us, and all the participants, Dr. Rafia, especially, and Dr. On. Professor Khalid Durrani, thank you for attending the session, and all the participants. And lastly, Dr. Pashmal Yusuf, thank you very much for this excellent presentation. I think the standard of presentations in the General Club, Alhamdulillah, has been great. And thank you very much for doing your presentation. With that, we would like to say goodbye, and we will have our next session on 7th of May. We welcome you all to attend that session. Thank you very much.
Thank you.
Allah Hafiz.
Thank you, Raza.
Thank you very much.